name's Steph, and I'm going to be talking about de Quervain's. The chief complaint with de Quervain's is typically wrist pain at the radial styloid, which results in an impairment of the wrist, hand, and thumb function, and it can be caused by repetitive wrist flexion. So like if you're doing lots of crafts or repetitive motion like cutting or anything like that. It impairs activities such as lifting, pushing, pulling, and gripping. Typically gripping is going to be the most painful. Symptoms can include stiffness, thumb weakness, paresthesia, sleep disturbance, and or pain tenderness over the radial styloid. To the left you can see just an MRI of the swelling of the tendons. In the first extensor compartment there's the little white arrows showing the anatomical influence. It's caused by stenosis of the first dorsal compartment of the wrist that contains the tendons, specifically the abductor pollicis longus and the extensor pollicis brevis. Pain is caused by the impairment of the gliding along the tendons, and this can result in a thickening around the sheath, and there can be some discrepancy among from person to person containing 3 or more of the abductor pollicis longus. And so a study found that typically if you have a greater number of these tendons, then it's going to be thicker in the compartment, causing more pain. For evaluation, there are 2 types of tests. There's Finkelstein's test, where you're pretty much just grasping your thumb and flexing forward. There's also a variation called Eichhoff's test, where you're just grasping like this for repetition, and you're trying to see if there's pain through that compartment. Treatment, typically you want to have conservative treatment before advancing to surgical options. And this can include a variation or combination of activity modification, so to stop completely what is causing you pain, Graston, eccentric training, so if you have a rubber band, like doing rubber band guns, or doing stress ball grasping, injection or iontophoresis, and then surgical treatment is only warranted if the patient is completely unresponsive, typically 6 months with unresponsive treatment to conservative. And so there are 2 different types. There is the open release or the endoscopic release, which you can see in the picture to the left. Endoscopically, it's just the release of the extensor compartment, trying to allow the tendons to glide through, and they might even cut some of the sheath away. But it's very difficult to protect the radial nerve in the branch, so that can cause a good deal of complications. And so no study has actually compared the results of open release endoscopic. And then just some fast facts. Severe cases of de Quervain's have been associated with the thickening of the retinaculum 3 to 4 times greater than is commonly seen. And the disease affects 1.3% of working women and 0.5% of working men in general. Any questions?